Welcome to NU 623, Adult Healthcare, Unit 6, Presentation 3 on hypoglycemia. Please make sure you do read the corresponding area of your textbook and click on any course links to help you understand the information. Hypoglycemia is considered a blood glucose level less than 55. You can see in your book on page 934 a chart that will show you the different causes of hypoglycemia, and that would be a good thing for you to look at. The subjective presentation can be very mild or be very severe, and the symptoms are classified as either adrenergic or neuroglycopenic. Your adrenergic type symptoms are going to be your sweating and your tremors, the dizziness, the confusion, anxiety, and your palpitations, whereas your neuroglycopenic symptoms are going to be headaches, fatigue, weakness, drowsiness, syncope, blurred vision, double vision, and some personality changes. Seizures or coma are severe presentations. Your objective findings that you are likely to see is an increased heart rate and maybe some PVCs. Patients would be diaphoretic, or they might have hypothermia or hyperthermia, and tremors. There's a positive Babinski sign. They may have some trouble speaking, and they may have some weakness on certain sides of their bodies, or they may even have an enlarged liver, but you're typically only going to see this if it's a alcoholic abuse issue that's causing the hypoglycemia. The differential diagnoses can be varied, and as you look at the clinical presentation, you can imagine how some of these diagnoses would present the same way. So you'll have to do a very clear workup and thorough workup for these patients. Determining the cause is essential to the treatment plan. If the patient is diabetic, you need to assess their treatment plan, adjust the regimen, and then reevaluate. If they're non-diabetic, you're going to have to do a good H&P for clinical clues to the cause. Whipple's triad has to be present for the diagnosis, and based on the absence or presence of the triad in additional lab results, you can ascertain the cause of the hypoglycemia. While a finger stick blood glucose can be done in the office if they're symptomatic, it's not going to be enough to confirm the result, and you will need a serum glucose level, so it's best to have them do some fasting lab work. If you do a CMP, you can get several labs at once to aid in the workup. This would include your plasma glucose, your creatinine and BUN, and your liver function test. In addition to that, you can do the other labs. The fasting glucose would be low, and different sources report to different thresholds between anywhere from 45 to 60 during symptoms or after a fast. Your liver function test can rule out hepatic causes. If it's abnormal, it might be hepatitis or cirrhosis or a hepatorenal syndrome. Renal function, if it's abnormal, the cause could be CHF, renal failure, or hepatorenal syndrome. And then your specific levels to try to figure out what's going on with the insulin. Your insulin and your C-peptide levels should be low when your glucose is less than 60. Elevated insulin suggests a factitious hypoglycemia, which means it's self-induced. It could have been from an overdose of medication or an insulinoma. Insulinomas are tumors in the pancreas. C-peptide is elevated when the insulin is endogenous, or it could be also in the use of sulfonylureas, an insulinoma, or an autoimmune process. A proinsulin level is going to be elevated when insulin is endogenous as well, but it could also mean an insulinoma or an autoimmune process. If all three are inappropriately elevated, this does suggest an insulinoma or sulfonylurea use. Now, you can check a sulfonylurea level, and if it's positive, this is going to indicate your iatrogenic hypoglycemia. If all three levels are low, this suggests a non-insulin mediated cause. A C-peptide to insulin ratio can also help to determine if the hypoglycemia is the result of endogenous or exogenous insulin secretions. See your text on page 936. Low insulin levels could be ketotic hypoglycemia, it could be alcohol abuse, it could be medications, prolonged exercise, adult glycogen storage disease, or glucagon deficiency. A high insulin level, C-peptide, and proinsulin with positive antibodies is going to point to the autoimmune syndrome. Serum cortisol can be done to rule out adrenal insufficiency, and your TSH can be done to rule out thyroid dysfunctions. In your subsequent testing, if you have hypoglycemic symptoms but the blood glucose is not low on the serum evaluation, to diagnose, then you may have to do what's called an inpatient observation test, where they do a fast and they try to induce hypoglycemia, and then they get the labs that they need at the point of the symptoms. Severe untreated hypoglycemia can be life-threatening, so your goal is to normalize the blood sugar quickly and treat any underlying cause. For the actual treatment of hypoglycemia, you're going to administer carbohydrate, either 6 to 12 ounces of fruit juice or 8 ounces of milk, or if the patient has glucose tablets or gel, that can be done, or IV dextrose can also be given. For management of reactive hypoglycemia, you're going to advise them to do a high protein and high fiber diet with low carbs, and they're going to eat small frequent meals. If it's medication or substance abuse induced, they're going to need supportive care, inpatient glucose infusions until they are stable. If an insulinoma is detected, they may require surgical excision, chemotherapy, or supportive care. And if there is an insulin-like growth factor secreting tumor, they may also need surgical excision and supportive care. Now, supportive care may include continuous or intermittent glucose infusion or glucagon administration and frequent monitoring of glucose levels. Frequent follow-up and evaluation is going to be needed based on the individual's symptoms and the treatment plan. You're very likely going to refer early on in the diagnostic process to an endocrinologist and have the patient also be managed by endocrinology. And they can also be referred for failure of your initial treatment plan. And if you have severe hypoglycemic symptoms, you may have to send them to the emergency room. There's a lot more detailed information on the treatment and management of hypoglycemia, as well as the etiology and the pathophysiology behind it in your text, so please read the corresponding part of your textbook that deals with this subject matter.